and I know there's a few midwives here in the audience as well, which is great to see. We're also celebrating LSTM's 125th anniversary, and some of the research that you hear today will really align with the excellent experiences of applied global health research that's taken place at LSTM over the years. So hopefully you're going to have a very enjoyable and insightful session. We've got a great panel here that we're going to have discussions with. And after we've had the conversation, we're going to open it up for questions and answers. So we look forward to that as well. So without further ado, I'm going to just ask the panel to give us a brief introduction about who they are and basically what they're doing. So should we start with you, Livuka?
So as I've been introduced, I'm Livuka Nsemwa. I am a lecturer at Tanzania, and currently I'm a PhD student at LSTM, and I'm working on the respectful maternal and newborn care. Thank you.
Livuka. And Tracey?
Hi, so I'm Tracey Mills. I'm a midwife and a reader in Maternal and Newborn Health at LSTM. I work mostly on the large programme of global health with Tina, so that's the NIHR Global Health Unit, and sort of primarily my research interests are around bereavement care, perinatal bereavement.
Thanks, Tracey.
Thanks.
Hi everyone, so I'm Deepika. I'm from India, and I'm also a nurse and midwife, and I do my PhD on parental involvement in care of small and sick neonates in India.
Thanks, Deepika. Yana.
Thank you, Tina. My name's Yana Richens. I'm director of Liverpool Women's Hospital, midwife and a nurse. And I'm very privileged to be the first director at Liverpool Women's Hospital. After spending 20 years in London in different roles, and my research interest, and I was very fortunate to do my PhD through the NIHR with Tina as a supervisor looking at fear of birth using mixed methods. So I'm delighted to be invited here today, so thank you.
Thanks, Yana. It's great to have the insight from Liverpool and the UK as well as some of the global insights. So thank you very much for joining us. Just want to go back to Livuka, and you mentioned respectful maternal and newborn care. And we know that respectful care is a human right. Women are entitled to have good quality, safe care, but also respectful care. And given that you're doing your research in this area suggests that maybe there's a problem. So could you maybe tell us a little bit about what the issues are and how you're going about solving them?
Okay, so thank you. So as you said, that respectful care is it's more than a human right issue. And in our practice in Tanzania and other low-income countries, we are more concentrating on the treatment and care and less on the women experiences. So women, they experience mistreatment during childbirth. Like there are several mistreatment which they are experiencing, like physical abuse, verbal abuse, non-consented care, like having some care without the woman's consent. They are experiencing like issues of detainment in the facilities because of maybe not enough funds to pay. Sometimes they don't get appropriate and timely care, which we say like they don't get the care on time despite reaching the facilities. So those are the kind of areas where they kind of experience, and they experience that with several reasons. Sometimes it's because of the healthcare themselves, they are not knowledgeable enough to know that they are not practicing respectful care, but it's also the system itself, it's not conducive enough to make those healthcare workers perform the respectful care. So that's exactly the picture, what is happening, and different initiatives that have been done by the government and other organizations working on that to make sure that at least we make these women experiencing to have a positive childbirth experience, because once these women they are not like satisfied with their care, the quality of care is not good, the experience affects them from coming back again to visit our facilities. So you find like the turn up of coming back to give birth in the facility is not that much promising. And if they don't come to the facility, means they have home birth, which is not like the standard home birth you have here, just home birth, which is makes them to end up with those mortalities and everything. So shall I continue?
Yeah, tell us a little bit about what you're doing to solve the problem.
So what I'm doing is I'm a part and parcel of this major NHRI unit program, in which one of the projects is to develop an intervention or band of intervention, in which from that intervention, we hopeful that we'll be able to reduce the disrespectful care. So in that big project, it has several phases, which is the development of the intervention, the implementation, and sustainability. My part is on the development phase, so development of the intervention, and the involving two countries, the Tanzania and Malawi. And since I'm from Tanzania, so I work on the Tanzanian part. So far what we did, we started exploring what is in the ground, like formative researches, finding out what is there. So we had community surveys with women who are delivered post-delivery at their home to have, in the context of the treatment they experienced. But also we had interviews with women, one-to-one interviews, like we interviewed 12 women from the 3 facilities involved in the project. And also we had focus group discussions with healthcare workers and the managers. So from there we had like a ground of what is happening together with other evidences from other literatures. So after that we used the method of consensus workshop, particularly nominal group technique, whereby we involved key stakeholders together with, when I say key stakeholders, I mean the healthcare workers, the women who were represented as, we call them community engagement and involvement. So some of the women came in that meeting, and we had group of health workers involving even the cleaners and thank you. So I was too low. Thank you for that. So we involved different people working in the hospital, because the respectful care is not only with midwives, so with only the doctors. So it starts even from the gate man, from the reception people, from pharmacy people. So sometimes women get mistreated or they're not respectful care from those areas. So in that workshop, we involved different groups of people. So within that consensus meeting, because we informed those invitees about the grounds of what we found. So we followed the procedures, and after that we were able to come up with the bundle, which we call respectful care bundle. And that bundle was further improved with the several meetings. We had several meetings with the CI group, and we have another group which was called the Appreciative Inquiry Group, or the champions. So I think I should not talk much about appreciative inquiry, but it's one of the approach we use in our project. Yeah, so we have those 2 groups who were involved together with the researchers to find out the strategies to improve the suggested components in the bundle. So from that we came up with we call it respectful care bundle, respectful maternal and newborn care bundle, in which it has 5 components. The major component is the training, and that training incorporates several things like customer care training, communication skills training, respectful care principles, and issues of professional ethics and code of conduct. Because these are the things which came up from the women and from I did not say about the findings, but the themes which came up from the interviews and the focus group discussion together from women and from the women and from the healthcare workers, they found that there was need for training. They found the healthcare workers, they are not trained enough on the respectful air. They just had other competences, or the midwifery competence or the obstetric competences, but they are lacking the respectful care principles. So the healthcare workers themselves admitted they are not knowledgeable enough, because there are questions asking them about what is respectful care, what do you understand by that? But also the women also, they did not know their rights. So both the training was concentrating on educating these women and educating the healthcare workers on respectful care. So the other thing which came up was the issue of behavioral change and the attitude. The women were saying some of the mistreatment they're receiving, they think it's just the healthcare worker attitude, is not the issue of competences or what. So they wanted some interventions which could impact the change of behavior. And supportive leadership also came up. So there are several other issues which came up in the interview, and those were the ones which led to the development of the bundle. So as I said, the bundle comprises of the training, comprises of issues of privacy and confidentiality, enhancing privacy and confidentiality in the facilities, which involved like supplying screens, gowns to the women, because for us, women, when they come in labor, it's like they just stay naked, because some of the hospitals, they don't have like maternity gowns to give the women. So those were some of the interventions which were involved in the privacy and confidentiality. But some of the very simple things, like to keep the cabinet secure for the files and so forth. The other part which we covered in this bundle, which was suggested, is valuing of staff, because it was also found like staff were also not motivated enough in their work, given the context of our area with the shortage of staff and overloaded with a lot of women. So they were like demoralized, and they gave that as justification for the mistreatment. So some of the interventions which were included in this valuing of staff component were like just providing tea and snacks during break times, insisting for them to have break times. The issues, we kind of introducing something called peer-to-peer appreciation, where we had a peer board in the labor room where midwives or staff could appreciate each other, like something like that. And then we also had recognition of staff, like best employee of the month. The staff can be selected and given a certificate just to appreciate. And because also staff said they're facing burnout, stress, and other issues, so it was also suggested to have like counselors for the staff when they have issues or have someone to talk to. They should have that someone to talk to. So there are several components in the valuing of staff. And the other one is the Sanabini supportive leadership, whereby the leaders were training. So we had also a training for the leaders to like help them to be good mentors and do the supportive supervision. And the other component was community engagement and involvement, of which in that part we did some local media educating women about their rights, but also we incorporated the health education, in the antenatal care services in these facilities. So we incorporated the issue of women's rights, so nurses could educate. It was part and parcel of the health education during the ANC. So I think I've covered, I don't know if I've forgotten some of the components. Yeah, thank you.
Thanks, Livuka. That's really important research, and it's great that you've taken the problem and developed an intervention to tackle that. And we might hear a little bit more about that shortly. But you did say some really important issues about the human rights and about women not knowing the rights. And some of the things you talked about in terms of things like leadership and valuing staff. I just wanted to bring Yana in and ask her, does any of this resonate with what's going on in Liverpool? Mike's a bit.
Yeah, no, thank you, Tina. And yes, it does. And absolutely agree that, it really is a fundamental right in terms of respect. And thinking about what you said there, we have the Maternity Neonatal Boys Partnership. So we have a group of service users that also we work very closely with to co-produce, and they walk around. There's something called 15 steps. So in the UK, we have something called 15 steps, where the service users, it was a woman who had a daughter who felt that she knew what care her daughter would get within 15 steps of being on the ward, of being in the clinical area. So now we have 15 steps where the maternal boys, service users, go onto the ward and they start talking to people about what does it feel like here? Are you respected? what type of care are you having. So it's really how working with users. We have awards to recognise what staff want. There's also something called the big conversation. So we have within 100 days of a new employee starting, the executive team go and talk to them and say, how is it? How is it for you? The recognition that if staff are well supported, cared for, then the women will be. And I think that is the important part. It's how you're treated and how you're supported, as you quite rightly said, about snacks, breaks, and how that whole ethos of being kind really makes that difference. And I think that, as you said, we also have patient advice liaison service where women and families can feed back, but always there's women that won't, you know, because actually you don't want to feel ungrateful, or and different women from different countries too. So there's also something we call intentional rounding, where somebody like me will go onto the ward and just talk to women and say, how are you today? How's it been? And try to gauge, what is that? Are you having your medication on time? Are you in pain? Do you need anything? Do you want a cup of the fundamentals about being kind? And that's not to really criticise. It's to see what temperature checking, what's happening. Because if we don't, as leaders and as people that really care about women, get out there and talk to them, we're never going to know. And so that is really great. So and thank you.
That's great, Yana. And it's interesting that a lot of the things you talked about related to respectful care, both of you actually, were fairly cost neutral. You know, being kind, you know, a smile, giving people information, protecting people's privacy. They're not things that are going to cost a lot of money. And I know that one of the big domains of respectful maternal care is having a birth companion, somebody to support you in labour. And I know that in the UK, you know, we very much support that, and the evidence from high-income countries suggests that that's very much what we should be doing in terms of improving outcomes. But we were all, I think, a little bit in shock when we got the COVID-19, weren't we? And you know, where things changed, and in most facilities then women were not supported to have a birth companion. Can you just tell us about your experience of that? And then I would really love to hear from Deepika, you know, how it is in India.
Yeah, no, thank you, Tina. So I was working in North London at the time, so very different. And we were the only, I think, hospital in the country at that time. We allowed partners to stay overnight. So we did, through COVID, support birth partners. We criticised. I was very fortunate to work with an excellent obstetrician who worked during the Ebola crisis, Benjamin Black, and he was so supportive and really drove that, looking at all the evidence and really thinking outside the box. And I think this is where our global colleagues really come in, because we kind of think what's happened there and how can we start to improve and support people. Because it was so scary seeing women on their own, and women that might have lost a baby, and I couldn't comprehend if I was losing a baby, being completely on my own without my husband, mum, and them not being able to see it. So all around the country you had families that never got to meet the child, and to share that grief, and the impact psychologically on staff, doctors, nurses, midwives, port, everybody was really traumatic. So I think I was really very fortunate, but I think what I've learned from that, and coming now to Liverpool Women, we've made that decision where partners now stay overnight. So on the postnatal ward, partners stay with their wife, girlfriend, whoever. I need to get the terminology right, so please forgive me. But you're allowed to have somebody stay with you, which I think at that time in your life when you need that is really important. Personal opinion, but it is working.
Yeah, no, that's great. And a really good example of, bi-directional learning as well. We can learn a lot from each other, which is fantastic. So what's the situation like for you in India with birth companionship?
So I would like to say that in India, like we have presently Lakshya, that is an initiative by Government of India for enhancing the respectful maternity care. So at the time of labor, there is a birth companion who is allowed along with the mother. But as it is a setting where there is less resources, we don't have enough privacy, so that only women are allowed as the birth attenders. So it is that we cannot have the men along with the women at the time of labor. And also, it is actually that the men are not allowed inside the hospital also, expect from that time of visiting hours. So it is a state that there is a birth companion, but it is not necessarily the partner.
Thanks, Deepika. And I know that when Tracey and I visited the facility that you're working at in Hooghly, the fathers were also not allowed to go into the neonatal unit even when they had very sick babies. Some of the fathers said that they hadn't seen their baby and the baby was 15 days old, for example. Now this is all tied in with the work that you're doing, isn't it, of care of the sick baby. Can you just tell us a little bit more about that?
Yeah, so as I already mentioned, it's like just the women who are considered the primary caregivers of the baby. And we know that when the babies are in the NICU or the neonatal intensive care units, so the babies usually are separated from the parents. And when it comes to our setting, that is in India, we have a limited parental involvement, and that too, the mothers are allowed to go inside the NICU to feed the babies. That is also restricted to those mothers whose babies are in stable conditions. Apart from that, if suppose those babies whose mothers like those babies who are on ventilator support, they are still there is a restriction for the mothers to come. It's just because of the situation that basically the mothers get emotional, or like the doctors and the nurses are not able to handle the anxieties of the parents, so they restrict the involvement of the mothers in that case. So it's actually very stressful for the parents at the time when the baby is in the NICUs.
So what are you doing about it?
Yeah. So, I actually work under Dr. Tracey, who is on this project on parental involvement. So, my PhD is on a qualitative study that is on identifying the factors that are influencing the involvement of parents in the NICU care. So, we have a family participatory care guidelines in India, but it is not yet widely implemented. So we have identified a lot of challenges in implementation of the family participatory care through this research. So our aim is to mainly develop some interventions that is to enhance the parental involvement. So what I can mention some of the challenges that we came across were like the women were like they were feeling they are the outsiders because they rely on the doctors and the nurses who are taking care of the babies, and they are they just blindly follow what the doctors and nurses tell to them. So they are allowed to enter the enter the NICUs, but there is a restriction indirectly, because they do not know whether they are allowed to enter or not, or proper information and communication given to the mothers about the babies. Most of the times, the mothers will be in a very stressful condition when they underwent the labor. They'll be in a painful situation. So most of the times, the caregivers will be coming and they will be meeting the doctors and getting the information about the babies. So there is a gap that the mother is not present at the time of orientation. Basically, the mothers are not able to like know what is happening to their babies. They just get to know that baby is not with them. So that is very stressful, and mostly, as I already said, partners are also not there with them. So then, like, the doctors are able to invite them, but mostly they give a call that you can come for breastfeeding. That's a time when the mother goes inside the NICUs. So what we understood was that there is a policy that mothers have to wear the gowns and like follow the aseptic precautions so that infection can be controlled. But they are not having a proper structured guidelines for all these. So we came across the parents, and also we had interviews with the health workers, and we had a consensus meeting as well with the CEIs. So where we got to know that we need to we got the areas of domains where we have to focus, and we have identified the main areas or domains of interventions were like the staff parent communication. So we've identified there is a need for training of the staffs, like how to handle the anxieties of the parents, like how to deal with them when they break some bad news about the babies. And also we came across the need for like some admission orientation checklist so that we can identify what are the important information that has to be given at the time of the admission to the neonatal units. And importantly, as I already said, since the fathers are not allowed to enter inside the NICUs, they were like so anxious about it, and they just were like pleading, like, if you can give us some options that we can just see our babies, at least some photos. This was their request. So we have also found out some ways for that as well. So this is all about the updates. Yeah.
That's great. And, you know, they're very vulnerable parents at that time. And so it's great work that you're doing. But the other group that are particularly vulnerable are those parents that the baby has unfortunately died. And this is really talks to your work, Tracey, doesn't it? I just wondered maybe if you could just tell us a little bit about the variations across these countries and also what you're trying to do to support those families.
Thank you. Yeah. So yes, stillbirth and neonatal death. So death of a baby before, during, or after birth is still a huge health problem globally. But what we do know is that sort of the majority of this burden falls on low and middle income countries. So about 98% of stillbirths and neonatal deaths are in low and middle income countries. But if you looked at the research, all the research is actually done in the high income countries. That's where all the resources are concentrated. So in the UK, the rate of stillbirth and neonatal death is probably around 7 or 8 times lower than countries like Tanzania and India. So yeah, sorry. Thank you. So the rates are, 7 or 8 times higher in many low and middle income settings. So burden of poor outcomes, so lots of need to improve care. So as well as obviously prevention, so we want as few women and their families to experience this outcome as possible. But I think whatever we do, there will always be some families who experience a stillbirth or a neonatal death. So it's very important, vital, that we provide respectful and supportive care to those parents whose babies die, because we know that the health of mothers, fathers and their families is really severely affected by the death of a baby. So not just psychological outcomes, but physical outcomes too, and long lasting impacts on the family. So this is a programme of work that Tina and I have now been involved in for about the last 10 years. So I've been interested in this area mostly experience in the UK as a midwife, and the privilege of being able to care for women whose babies have died, and the seeing really and understanding the difference that good midwifery care can make to these families. So just like the rest of the work that you've heard, we started off this work in Kenya and Uganda by exploring the issues. So talking to women, talking to their partners, talking to their families and health workers about their experiences and what some of the issues were. And then we gathered all that data together, looked at what the main problems were, and then tried to think about how we could put together some solutions. So one of the things that really struck me was actually the commonality in experiences. So the accounts that the women and their partners were giving about the impact of stillbirth and neonatal death on them was really similar to what women told us in the UK. So very, very similar impacts. There were some issues in the care, you know, lack of information. I think a lot of commonality with what Livuka was saying about some of the issues with privacy and lack of emotional support from health workers. And we could really see how key the relationship between midwives particularly and the women was in providing good support. So we've worked very closely with our partners in Kenya and Uganda, and with women and their partners and their families to try and think about some ways that we could improve care. So we've developed some interventions, some changes. So some of this has been around improving education for health workers. So that's really important. That was a real focus of what the health workers told. They just hadn't had enough emphasis on this in their training to know how to care for women and families properly. So that was one thing. Also trying to put some structures into hospitals to improve care. So we know you can train people, but just training people doesn't actually make them change their behaviour. So you need to put things in that encourage people to do the right thing. So we've developed an intervention where we train specific health workers to be champions for bereavement care, so to have a particular focus and emphasis in this area. And we've also developed an intervention to try and address the need for better support when women go home from hospital as well. And so to develop some peer support, so support by women who've had a stillbirth or a neonatal death in the past. They are in a unique position to understand needs and be able to provide support. So we've trained and supported those women to link up by phone with mothers who've just lost their babies, and so that work's ongoing. We've done several levels of study, and we're doing a large-scale evaluation in Kenya and Uganda now, a trial. So it's very exciting.
Thanks, Tracey. And I know in Liverpool there's also lots of really good innovations in bereavement care. Do you want to just tell us all about them?
Yeah, no, thank you, Tina. There's always something wrong, isn't there, about talking about birth and death in the same sentence. It just seems totally wrong. And so we've also been looking at the father's experiences, you know, how many marriages actually don't continue following the death of a baby and a child, and thinking about what are we doing for fathers. So it was really thinking about involving sport, and we've got Liverpool Foundation, well, Liverpool Football Club that's got a foundation, and so now we've started a football team. So our bereavement team is called the Honeysuckle team, and we've got a Honeysuckle Foundation, Honeysuckle United, that are playing football, and actually they're going tomorrow night, and they train at Liverpool, and there is a football team, and they have the name of their baby on the back of their shirt. We're doing an evaluation with Edge Hill University, and we've just had that report, which we will be publishing, and it's really looking at the psychological well-being and the outcome for the dads. And what's really interesting is how they've spoken about how their relationship with their partners have improved, because they feel that they can talk about it with somebody. There's that commonality, there's that shared experience with another man, and you know it's starting to grow, and it's starting to actually, Sunderland are starting one now, and so London have got Sands United FC, but it's how do we start to think about that potentially globally, that dads need something, they don't know what, they know they need to talk to somebody, but they didn't know how to talk to their partners, because all they want to do is to protect them as the dad. So that's been really powerful, and what we're seeing from that, Tina, is the more use of the cold cots. So we do encourage, or not encourage, it's really up to the parents. You can take your baby home. You're encouraged, you know, whatever you want. We're looking at lactation. Some women have asked, could they continue to lactate and save their milk and give to another baby? Choice as well around where to give birth. We know, I know of a case in London where the woman went and had a home water birth, her stillborn baby. That was her choice. She'd made her plan. I want my baby at home. I don't want to be here with everything. And we know, again, it's about risk, but how do we support women in the most important part and time in their life? For some, might never have another baby. And so how important that is. So it's really kind of pushing those boundaries, but thinking about what is transferable and what we can do. Because we know years ago in the UK, we're in similar positions where nobody spoke about it. And now at Liverpool Women's, we're having women come back 30 years later, say, my baby was born here. Do you know where it is? You know, do you know what's happened? I wasn't encouraged to talk about it. So it'd be really good. So thank you for asking that.
Yeah, I mean, that the football initiative is excellent, isn't it, for fathers? And you know, we always say that football is the universal language. Wherever you go in the world, everybody knows Liverpool, for example. You know, of course they would. But you know, I'm sure that would be transferable to Tanzania and India, because you know, when we go there, everybody's mad about football as well. So it could be a way. And
It's not all Liverpool.
It doesn't have to be Liverpool at all.
Yeah. I think you're right. I think it's really interesting thing to think about, because again, this thing with the difference between the way that the men and the women were behaving was something we saw very much in our research as well, and how men did feel very strong emotions but felt unable to express them, because either it wasn't perceived as the masculine thing to do, or they felt their role was very much around supporting their wives in, you know, what had happened. So I think something like that, it did in Uganda. They had a spontaneous formation of a male community engagement and involvement group, and part of that was around giving the dads a sort of forum to talk to each other. Really important.
Yeah, that's great. And the time goes so quickly, doesn't it? And I know that James has given me the nod here that we probably need to start getting some questions, which is great. But I just wanted to end this part by saying it's fantastic to hear, you know, such great midwifery initiatives, you know, given that this is the week of the Independent Day of the Midwife, that it's brilliant that we're able to talk about midwifery-led projects. And I think there are more and more career pathways for midwives, and lots of the funders have recognised the importance of midwives identifying the problems, as we heard from, you know, Livuka and Deepika, and then doing something about it and conducting some really robust research. So it's fantastic to hear. And I'm sure if anybody wants any questions answering about that, we'd be happy to answer them. But I think we're going to go to questions now, and we have questions from the audience and also online. So lady at the back, maybe you could tell us who you are as well.
I don't work in your field, but I have a question for the lady sitting next to you.
Okay.
You said that the ladies did not have respectful births and that they did not know their rights. How much does illiteracy contribute to that?
Okay, thank you. So if I don't know my rights as a woman or as a mother who is giving birth, am I audible? Yeah, so she cannot hear me. Okay, so if I'm a mother and I don't know my rights as a woman or as a mother during my childbirth, so some of the things will be done to me and I'll just take as normal, while they're not okay, because I don't know what I'm supposed to get. Like, for example, in terms of informed consent. So if I don't know that it is my right that before anything is done to me, I need to be given enough information, like what is it, what are the benefits, and then for me to be involved in the decision making. So if I don't know that is my right, then I won't ask for it. So for us, educating women about their rights, I think it's more important because they'll be aware of what they're supposed to get and they can demand. So it's like kind of empowering them also. And that will, together with the healthcare workers, to help to for them to receive what they're supposed to receive.
So I think the lady also wanted to know about the difference according to literacy. So are the educated more likely to know their rights than those who maybe have not had the same education?
Okay, thank you. So I thought, how is it affecting me not knowing my rights? How is it affected not receiving it? So in terms of literacy, yes, it is related. Those who are like less illiterate, they are less knowledgeable about their rights because their level of exposure is different from those who are educated. So even living just in urban compared to rural is quite different. Yeah, so I can say that. Thank you for elaborating the question.
Yes, thank you for the questions. So, Ron?
It was more of a comment really following on from I didn't want to mind you. Hello, I'm Sean. I'm a research midwife between Liverpool Women's and LSTM, where I'm on secondment. So it was more of a comment really about empowering women with their rights. I feel like it just highlighted really the impact that midwifery care that's respectful. It goes far past childbirth, doesn't it? So that being that empowered to know what your rights are, you can carry that through to medical conditions, you know, as you're getting older. It'll be shared with like your sisters, your daughters. It's like changing the narrative, isn't it? And it'll spread out long after the research is finished, really. So that just stood out to me as really important. So thank you very much for sharing it.
You're right, Sean. It you know, once you're empowered, it can impact on all parts, all aspects of your life as well. There's a lady at the back, and then
I think
sorry, Hattie, were you waiting? Sorry.
Yeah, the lady.
Thank you. Yeah, I'm Hattie. I'm a program coordinator here at LSTM. So with it being the International Day of the Midwife coming up, I wanted to ask, do you think historically and still currently that midwives have faced more barriers engaging in a career in research than, say, you know, medics, like people doing a medical degree? What's your opinion on that, both in the UK and globally as well?
That's a really good question, Hattie. I think that, you know, historically it was more of a challenge. We haven't had the same career pathways and the opportunities that some of our colleagues have had, but that is changing. And I think has been recognised that there is a need for that. I know Tracey is quite involved in this. Do you want to say anything?
Yeah. Yes, I totally agree with Tina. It has been really hard historically. I think it's been recognised, one, that it's really important to have the people who are providing care generating evidence to improve it. So midwives are really important. And I think there's been a shift, particularly with some of the funders. So the NIHR, which is, you know, the research arm of the NHS, really has been doing an awful lot of work in this area, and is providing really good support at all stages careers now, right from first exposure to research to funding for developing applications for study and supporting people right through their careers. And that's something that when I started out in research just wasn't there, and that is a wonderful development. And I think a lot of that recently has been influenced by Professor Jane Sandell's role within the NIHR. So she's a midwife and has been very active in that area.
What about in India?
Yeah, so in India, as Tracey already said, that academies like NIHR or like funders are like trying to have like more research in our place. So because of that, we are getting some opportunities to represent globally. So that's why I'm here today as well. So otherwise, if we actually think about the education and research for midwives, first of all, I would like to say that there is no midwives concept in India till now. Like we have basically we had only the nurse who are working as the midwives as well, and they will work under the obstetricians. Like they basically assist the obstetricians for the care. So we like around in 2018 we have some midwifery practice guidelines in India. So it's just that it's not yet completely implemented. So we are just we might look into that as well. Maybe in the coming years we can have it. But apart from that, like we usually have a pathway, like we just work in the hospitals as nurses, or like we can just go and work in teaching profession as well. So like still limited, and we are hoping that it might increase with NIH and other funders.
Thanks to Deepika. And I should say that when Tracey and I did our PhDs, there was very few academic midwives that were around, but we both had very good obstetric mentors, didn't we? That we were very grateful that helped us along our research journey. Lady at the back.
Yes, so can you hear me? Yes, I tend to. I can come from this from all angles, but I'm a retired health visitor, and I was also a breastfeeding coordinator. In the area I've heard in Knowsley, which is the most deprived area of Liverpool, well, sort of Merseyside, and somebody said something about the commonality, even the thing about education and literacy. I have had the experience of walking into Alderhay with a family whose child we were basically beginning to realise had cerebral palsy. And as I walked in the door, the father handed me the child to carry, because it was a family that wasn't well educated and were basically scared of doctors. And if I hadn't been there with that family, I'm not sure they would have really communicated at all. And the child was diagnosed in front of us all with a major disability. I have to say thank you to the women's, because I'm also a new grandmother, and my grandson was born with a difficult delivery, luckily very normally, and survived. But if the father hadn't been there, if my son hadn't been there holding the baby, I think the baby's mother would have been much more distressed and probably would have had more problems with breastfeeding. The question I wanted to ask about India is, do all mothers who might be going to have a difficult birth and maybe at risk of stillbirth, is there equal access to suitable medical care or not?
So thank you for that question. So in India, we have like a large population, more than 1.3 billion. So like we only have like tertiary medical care facilities in cities, that is in urban areas, and a lot of population is served by the primary health centers. So we have the capacity building for the primary healthcare workers for conducting institutional deliveries, and as per the reports, like most of the deliveries are like nowadays institutional. But as she was citing that when it is a difficult delivery, it's like very difficult for the mothers to access to the specialized care, because they have to travel like around 200 to 300 kilometers distance to reach to a like tertiary health center where they can receive specialized care. The times what happens is like they just are deprived of the care at the right time, and they end up with complications of like hemorrhage or like some maternal deaths as well. So that's a serious concern in India as well.
I think this lady and then.
Hi everyone, thank you, the panelists. It's a really interesting topic to discuss today. I just have one question about the role of the midwife on the climate changing situations, and what's the role of the midwife on for climate action and for building the resilient of healthcare system.
Yeah, that's a difficult. I think that's quite a difficult one, isn't it? Really.
I gave it to you.
Yeah. Yeah. So I think the sustainability is really important, isn't it? So I think using the range of skills in the correct way, making sure that we deploy our health workers to, as efficiently as possible, and that there's a lot of our work is around low cost solutions to problems. So also, making sure that what you do is context appropriate and is going to be suitable for the situation. Certainly a lot of the issues we see in some of the contexts we work with, access to care, are very impacted by climate change. I mean, I was last year in Pakistan and witnessed firsthand some of the huge devastating impacts that the floods had, and that's all very related to climate change. So this is something that midwives are going to need to sort of incorporate into their practice more, I think, and think more about sort of these impacts and how we can address them. Excuse me.
Thank you. What a great question. Being that IDM is related to climate change this year, and I think that it's really thinking as women as well about the political factors, how we as midwives, when we talk to our women, when we're with them about that education, about the feeding. I mean, we've all gone, haven't we, from disposable nappies in the UK, from those that my mum used, the terry towel in, and used to wrap that. So how do we start to have discussions and really start to think about how we're impacting on that climate change within our own environments too? So for example, at Liverpool Women's, how much stuff do we recycle? What do we do when things are out of date? What do we do with medication when that's out of date? It's a disposable, almost like a Primani economy, where we think we can wear it once and throw it away. So how do we start to rethink slightly differently and be more political? So as midwives, there's this, are we political enough as a workforce? So I think there's something here that collectively we need to start to consider. And even think about when you go to the canteen, what are we doing? Where are we getting this from? What are we doing? Is there any plant-based options? So thinking really challenging and having those conversations. So great question.
Yeah, thanks, Yana. Livuka, and then we've got a question online, I believe.
Yeah, so I wanted to speak in terms of we as midwife advocating for climate change. So because we are part of the group, we are part of the community, so we can use this platform as midwife to advocate for preserving the environment, because once there are those climate issues, women are also part of them and they're affected. Remember those like women who are in areas where there are floods and what birth should go on. So imagine a woman who is giving birth and then there are those devastated conditions. So we have also a role to play as midwife, like advocating for global safety, because we work for the women, and women undergo birth whatever the circumstances. Thank you.
Livuka. Okay, we'll have this lady here and then we'll go online. Sorry. We could do it an extra hour, couldn't we, really?
Thank you. Really interesting conversation. My name is Noon and I'm a junior doctor, but I've also completed a PhD where I've looked at maternal mortality in Sudan, which is where I trained. And although it wasn't really the primary theme of my PhD, I've done, from a lot of the interviews, a lot of themes came about midwifery, training of midwifery in Sudan, regulation, and I'm currently working on a paper. And one of the main things that I'm trying to get across is that it's not very clear what midwife means. There are 7 different types of healthcare practitioners who would have the term midwife, and they have very wildly different competencies and abilities to kind of work. And in a sense, that really limits the progression of the profession in Sudan. It's over 100 years old, but it's still not very clear what the term means. So I'm just curious to know, because obviously you've it's quite a global kind of panel. How is the situation like in other countries, and what exactly does midwife mean in different contexts?
Yes, and another very good question. And I think that, you know, a lot of us adhere to the ICM's definition, although I know that wherever you go around the world, people talk about lay midwives or skilled birth attendants or nurse midwives. So it does vary quite a lot. So maybe you just can quickly tell us about Tanzania.
Okay, thank you.
Definition.
Yeah, thank you. So we also rely on the ICM definition, but in practice is like when you go to the maternity ward, you'll find we have nurses and we have midwives working there. So as long as you're carrying a woman in the maternity ward, we just call you midwife. So you kind of have nurses midwife, because as previous historical, we had like the lower level, you are trained to 2 years as general nurse, then after that you can go to psychiatric or you can go to midwife. But when we advanced to degree level, it was just general nursing. Like I did general nursing in my bachelor. Then after that, recently now we have established this masters of midwifery. So now you can go for masters of midwifery. Once you're done with your master, then you're recognized as a midwife specialist. So it works in both ways.
Thanks, Deepika. Livuka, sorry. I should know the difference, shouldn't I? But really good question. And I know people have tried to unify the definition WHO and ICM, but people still use different terms for people with different qualifications and levels of experience. Did we have a question from online?
Yes, there's actually quite a few questions now.
Okay.
First of all, Eunice Gashomi from Zimbabwe. Thanks, Livuka, for what she's talked about. Says there's a lot of similarities from what she's hearing. And I'm happy, if you're happy, I'll put you in touch with her at the end of this so you can share those learnings.
Thank you.
Also for you, someone has asked, in terms of respectful care, do you find that adolescents have special needs, and are they accounted for in your research?
Yes, the adolescents have special needs, just them being adolescent young. So sometimes they experience this disrespectful because of the discrimination of age. So just them coming to the hospital, and remember our culture and African culture. So sometimes they've experienced, I can say it is more than the others. Thank you.
Okay. There's also a question from Professor Adatoro Adagoke, who's a professor of health inequalities at Buckinghamshire, I can't say that today, New University. And they ask, that some of the drivers in terms of disrespect is around resources and a lack of resources. So how does the panel feel about capacity strengthening?
Yeah, no, I totally agree that, you know, that resources do play a part, but I don't think that they're the only part. I think that we've heard of examples today already of things that people can do that are actually very resource neutral. You know, just the way you welcome somebody, giving them advice, getting their consent before doing a procedure. So I think that, you know, the health system and the resources, yes, you know, it can play its part, but I think there's still a lot we can do.
There's also a question for Yana. I'm sorry, I think it might be from the same professor, I'm not sure. It says, how would you describe maternity care experiences of women from minority ethnic backgrounds in Liverpool? And what are the key strategies being employed to improve access, experiences and health outcomes for those women?
That's a really great question. I think it's not only relevant, as we know, to Liverpool Women's. LSTM, there's 2 midwives working alongside Tina at the moment. They're being seconded to look at this very subject, and you know, it's working and discussing with women what are their needs and what is happening within those communities. So that qualitative research is being undertaken and actually being presented some of the outcomes at the Royal College of Midwives IDM conference this year. So, you know, from my earlier work, really talking to women about their experience, it was looking at that AAAQ model: accessibility, acceptability, availability and quality. Women, if they don't know about the care, they won't go, they book late. Women that are not treated kindly don't go back. So it's really, and the quality. So how do we engage with those local communities? And that's what we're doing, and that's how we're doing that. You know, we know that communication plays a huge part in terms of translation. So at Liverpool Women's, we have what we call interpreter on wheels now for women, available in over 70 different languages. And, you know, in the UK, I believe, this is my personal opinion, when we start to look at risk, I believe that we know that women from Black, Asian, minority backgrounds have poorer outcomes in the UK. Now, if that's the case, they should be treated at high risk from booking. Our maternity tariff does not allow that. They really are classified as a lower risk. So lower tariff means that you have less money to spend on that care. So when you talk about resources, that's the political part. And this is where we as midwives, obstetricians need to come together. My belief is that women, if you know the outcome's going to be poor, and we can identify that, you need more care. You know, so we still need to kind of think about the long term. How do we do that? And that's why I believe the outcomes are not changing. And we haven't seen a huge change in the 30 years I've been a midwife. And yet we've spoken about this. So it does concern me, and constantly does. And that's why we have to be political. But that's why we have research. And we need the evidence, because, you know, we know that politicians and commissioners cannot distract from that evidence if we present it. So we do the right thing, not the easy thing. Great question, thank you. Good.
There's actually a couple of questions for Deepika as well. The first one is that Sabina thanks you for such a great male initiative and asks, from your experience, what's the topmost support that men have said that they need?
Pardon, can you just...
What is the most important thing in your experience that men need from your research?
Yeah, so basically in India, the men are not having any role in terms of neonatal care. So I feel that we must have a space for the men to be part of the maternal and neonatal care. There is a traditional way of thinking that it's just women's responsibility, that and men has nothing to do with it. Men are just the like role of like caretakers of the women. That's it. So we have to actually educate the families about how men can also be a part of the neonatal care, and even they can support, how they can support the mothers for encouraging them for breastfeeding, or like at least give a moral support to the mothers when the baby is when they, or like in general, for even for the general care of the babies, healthy babies.
Thank you. And it was quite interesting, wasn't it, though, when we talked to the men in your study, that we were talking about them getting involved in delivering the care. And in actual fact, the men said to us, we don't want to be involved in delivering the care. We just want to see the baby. So, and they were very, very clear about that, weren't they?
There's also a question from Dr. Nalim Badwaj from New York, who James tells me is an alum of LSTMs, and they've asked, in terms of midwives and doctors working more in a more coordinated manner to ensure that people get information from ICU when they're not allowed into that space. Is there a role for midwives as an interface there?
Yeah, so as I already said, we just have the nurse who's working as a midwives, and then like the nurses who are working in the labor room, they are working separate. They are not at all related to the neonatal intensive care units. So we have a separate group of nurses who are working in the NICUs for the care of babies. So I think maybe we can also think about this angle of how these nurses who are working in the labor room can collaborate with the nurses in the NICUs, and that would be a good idea. Maybe think about it.
Okay, I think there's just one lady at the back that wanted to ask something. I think it was after Yana had spoken. I think.
This is the breastfeeding again. So this applies to all your hospitals and all your research. How successful are you if the mothers aren't even allowed into ITU, which of course doesn't apply here, but how successful are you at helping the mothers produce their breast milk and to produce breast milk for their children? And how many of you are looking at research, not just about the ethnicity, but about the social, economic position of families? Because I'm sure if you're a doctor from an ethnic minority, you know you're much more confident about your delivery. So it's exactly the thing I said about Knowsley, and someone else has said about ethnic minority. We need to look at the people from the low income and show they're the ones that are risk, whatever the. But I'm really interested in the breastfeeding, and the reason I'm knowing, I would love to know from the women's, what are the breastfeeding rates doing in Britain, and also how are you managing to maintain them for the babies at risk in the ITUs in your other researches?
Yeah, I mean, from what I saw, the breastfeeding was pretty good, and you do have kangaroo mother care, and you have individual rooms, and the women do come to feed, don't they? And then they go back to the wards. But maybe you can just elaborate on maybe what your breastfeeding rates are.
Yeah, thank you for that question. I'm not pretty sure about the exact statistics, but I can tell about from my experience what I have seen. So like in India, we have like in hospitals that we have trying to ensure that there is an immediate skin-to-skin contact and early breastfeeding is initiated. So that is compulsory guideline in our hospital, and that is the only reason that even this family-centered care philosophy was like that was incorporated into our hospital as well. So we got to know that from the perspectives of the staffs, that the mothers are not very interested to come on the initial days for the breastfeeding, mainly because they are in very like high pain, and also they are undergoing a lot of discomfort after the labor. So even after repeatedly calling them, like some of them refuse to come and breastfeed the babies. So the doctors and the nurses are they try to maximum encourage the mothers, that telling the importance of exclusive breastfeeding, and that is the way they are trying to ensure that breastfeeding is possible for all the mothers, for all the babies. Sorry.
Thank you. I know that we could keep on talking, and it's been great to have this conversation, and there are still some questions that aren't answered, but I think we do need to draw it to a close. But I just want to thank the speakers for sharing their insights. I also know there's a lot of experience in the room and online as well. For those of you who are in the room, we are hanging around and there are refreshments. If people want to talk to us or have additional questions, then that would be great. People online that we haven't answered questions, we're happy to answer it, answer your questions afterwards. And we do hope those of you who are online will join again for future conversations at LSTM. I think that the take-home message for me from what we've heard and the questions is that respect, kindness and communication are key to absolutely everything we do, and that all women deserve the same care, whoever they are, wherever they are, and that midwives can play a pivotal role in making that happen. So thank you to everybody, and we hope to have a chat to some of you outside while we get some refreshments. So thanks everybody.